Washington University. I am a neurologist. It's clear that there aren't enough neurologists in this world with us giving 2 talks, so you have to put up with us for 2 sessions today. I refined the title of my talk a little bit because I think the original one implied that patient advocacy groups might contribute to spread of dystonia, which isn't the case. I really want to emphasize the role of patient advocacy groups, how they've really helped us in understanding blepharospasm and advancing the field. These are my financial disclosures. It's always a good idea to know where folks are aligned with respect to how they're paid. I'm employed at Washington University. I do receive research funding from various support groups, foundations that support dystonia research, including the Dystonia Medical Research Foundation, the NIH, the government support there. And I do serve advisory roles as outlined here. These are the objectives that I hope to outline and address today. I want to first describe the role of patient advocacy groups with emphasis specifically on advancing research and how that's been successful to date. I want to identify current research priorities in dystonia and how we're chipping away at those to understand the disorder and advance treatment and hopefully come up with a cure at some point. I want to discuss the importance of characterizing clinical features and the natural history. So what does blepharospasm, what does dystonia look like? And how does it change over time? So this relates to the spread of dystonia as far as going from one body region to another, and why in some, why not in others. And then we're going to describe specifically those characteristics in people with blepharospasm. So this all starts, I'm a clinician, and I see patients with blepharospasm, various forms of dystonia, and it's very common, right? I have dystonia or blepharospasm, now what? And this really is the impetus of how patient advocacy groups developed, right? So the DMRF in 1976 was the first probably true dystonia advocacy group. BEBRF followed in 1981. And it was the Blesbergs and the Costers who had experience with dystonia and left their appointment with their doctor and said, what can I do to advance this? How do I connect with the community? How do we do this, either intellectually or financially, and what does this take, right? And so patient advocacy groups, as we've been discussing today, bridge these patient needs, right? And this happens in many ways. This happens at a community level, right? So community support meetings that Dr. Holtz has set up in St. Louis, and certainly there are other efforts. Education, right? This is part of that. I'm standing up here trying to educate you, and you're educating me at these tables. And we're trying to understand better what the needs are of the patient. So that's a reciprocal conversation. And then, of course, with that conversation come up the questions of how can we do this better? And so that's what leads to research. And so the BEBRF specifically, their influence in research, their goal is to promote search for cause, cure, better treatments in blepharospasm, and specifically related disorders that involve the face muscles. This is a subtype of dystonia, right? So this is one of many dystonias. I'm a neurologist. I think of blepharospasm as a category, a subtype of dystonia. So I think a little bit more broadly of this, but this group helps allow us to align and make sure that we're addressing the specific questions. And this plot below, while small, is the number of publications, research publications, right? So these are scientists who are thinking about dystonia, publishing their results and advancing the field. And so this was the early 1900s. It was pretty stagnant for a long time. The DMRF, right, One Patient Advocacy Group or Foundation, the BEBRF appeared. They put in a lot of effort educating and providing this link between patients and researchers, physicians. And it's no coincidence that there was an absolute exponential increase in the number of research publications thereafter. So these groups have a huge influence on what we're trying to do in the field in understanding this. So specific to research, right? Research, is a slow process. We make an observation. We have an individual on the left here that we observe with abnormal movements, dystonia. And we ask various questions, right? Why this individual and not others? What potentially caused this? Why this age and not another age? There's lots of great questions that we can ask. And we feel, we make that observation, right? This individual has a neck turn, they have a arm extended. What is causing that? It could be a specific question. And so we look at the literature, right? I, as a physician, has anyone else explored this? I don't want to waste my time, I don't want to waste others' time and resources. I review the literature. I don't think you can see my pointer, but we're just working around the circle here. I create hypotheses, right? Perhaps a brain disorder, dysfunction of the brain contributes to, causes blepharospasm. And then I test that with experimentation. I analyze the data and then I produce that. I report those results. And this is iterative, right? So we've learned in the field, we've created new treatments, botulinum toxin, DBS, oral medications, as a result of this process. This isn't easy to do without great ideas, right? Conversations here, sitting down at a table and hearing what the patient's needs are, what they need, in the clinic. Money, right? Money makes the world go round. We need funds to support researchers, to grow young faculty in the field, and to get them interested and protect them, to be in a research laboratory, to study this, to be in the clinic, seeing patients with blepharospasm. So patient advocacies produce that as well. And then collaboration, right? We can't do this on our own. I have great ideas, others have great ideas. I'm a neuroimager, there's geneticists, there's all of these components that contribute to blepharospasm. So patient advocacy groups bring people together, right? So you heard about Dublin, Ireland, we had a dystonia symposium, international symposium. The BEVRF was there, the VMRF was there. Some of the greatest world researchers and clinicians in dystonia were there. And so it wouldn't have been possible without these foundations and these support groups to do that. So this is what keeps this wheel moving and allows us to make progress. In the field of dystonia and blepharospasm, there have been dystonia research priorities defined. Right? So this is at the level of the government. The NIH sat down with some of the world experts in dystonia, hearing from patient advocacy groups what are the needs. They sat down and they published a paper defining the research priorities in dystonia. I've highlighted on the top the clinical characterization, right? This is what does dystonia look like? How do we identify the field? And the natural history. And specifically, this kind of relates to that concept of spread, right? How does the disease progress over time once somebody's diagnosed? So those are the portions of this first talk that I'm going to talk about. In the second portion later this afternoon, we're going to step up our game and we're going to start talking about more specific components of genetics, neuroimaging, molecular biochemistry, and I'll try my best to define that and put that in relevance. And of course, all this requires advanced technology, right? So I've got an audience here that I didn't have before because I'm on YouTube being broadcast. And so that's an example of technology that allows us to reach out. Obviously wires that we can place in the brain are advances in technology, so there's a big component of that as well. And so those are things that are happening behind the scenes that really allow us to progress as well. So why study what dystonia looks like, clinical characteristics, and the natural history, right? First and foremost, this matters. I can, as a clinician in the clinic, talk to you about your disease, right? I see that you have had onset of squeezing of your eyelids over the last few months. I can sit down with you and talk to you. This is what we anticipate over the next few years. This is how we may be able to treat this well, and these are the risks and benefits associated with that. So clinically, in that patient-doctor relationship, that's important. And as a patient, you want to know, right? What does the future hold? So we want to be able to tell you that in the best way we can. We also want to be able to perform research and conduct clinical trials, right? So clinical trials in medicine are what allow us to advance therapies, right? We don't want to give something to someone without knowing how it's going to affect them, right? A drug, a treatment, a surgery. We want to understand that. And in order to test a medication or a surgery or an intervention, we really need to understand the population that we're studying, right? What are we trying to treat? Is it specifically eye closure and blepharospasm? Is it the case where there's blepharospasm, eye involvement, and neck involvement? Is it a genetic form of dystonia, or is it a form where a stroke or a neurodegenerative disease caused it? And so when we do these clinical trials, we want to make sure that we set forth with a very specifically well-defined population. Because perhaps if we include people that don't fit that well-defined population, we're not testing what we thought we would. And if the results are negative on the backside, maybe it's just because we didn't include the right population. We didn't connect all the dots with respect to our prior knowledge and what that is. We want to be able to improve that recognition, right? I want to be able to look at you and determine that you've had blepharospasm as a clinician. I want to get you into that clinical trial if you're willing to and to learn about that. We want to predict the natural disease course. If I don't know how blepharospasm progresses over time, right? We're going to talk about spread. If I don't know how it spreads over time, where, when, etc., and I give a drug, an experimental drug or an experimental surgery, then I don't know whether that drug or that experimental therapy altered the course. So I really have to understand what the natural course is of that disorder before we can really define whether these drugs are altering that. And then, of course, detecting meaningful change, right? In research, we're biased. If I give you a drug, you may feel like it gets better, even if it's a sugar placebo, right? I, as a physician, have that same bias. I want this to work. I want this experiment that somebody's pouring funds into and working, and that can create extreme bias in research and medicine. So we need to be able to detect meaningful change, and we need to be able to do that in a meaningful unbiased way. So that's a component of research as well. One huge component to our research has been the Dystonia Coalition, and this is a patient advocacy group, including the BBBRF, supported effort. This is an international effort involving 49 sites over 7 countries. We have enrolled now over 3,600 participants with dystonia, so isolated, meaning that's the only manifestation of the disorder, dystonia. And I'll show you numbers that include blepharospasm. It's a large portion of this. This is an ongoing study. This number continues to grow. What we're collecting in this population are standardized clinical data, right? So all of the neurologists, all of the physicians enrolling folks into this are collecting data. How old are you? When was the onset? What regions of the body are affected? How does this progress over time? How is this responding to therapy? In addition, we're collecting video, right? So those videos allow us as researchers to, again, in that unbiased fashion, I can pull any of these subsets of this population out of this, look at those videos, or give them to a resident physician or a young physician who's relatively unbiased and allow them to objectively measure, right, the degree of dystonia and allow them to categorize them into an appropriate research study. This has been hugely productive. This has resulted in over 200 publications now. And these data are available to any researcher across the world. So if you have an interesting question, you're interested in giving research, right, go to this website. We can look at the data set. You can come up with a great idea. These data are available to anyone. So this is a great initiative to help understand dystonia. This is highly supported by patient advocacy groups, right? So there are over 17 patient advocacy groups who support this. And why is this important, right? A research study like this, an international research study like this, takes a lot of effort, a lot of coordination, a lot of financing, a lot of data storage, all of these things. And so patient advocacy groups chip into this. They chip into this, intellectually with effort. They help to reduce that overhead research cost by setting up some of these components, right? So setting up a research database, for instance. They offset the administrative burden, right? So they can advertise these studies so that we don't, as clinicians, have to do that. Patients hear about this, get enrolled, and it advances. They guide the specific research priorities. I, as a part of this Dystonia Coalition, am meeting with these international components. We will take your ideas, your thoughts from this meeting. The patient advocacy group is present at these meetings. They're telling us what patients need, what matters, right? So I, with dystonia, I with blepharospasm, notice that all my friends in my support group have depression, right? Is that a result of the disease? Is that a result of the stigma of the disease, right? Is it the neurologic component or is it the stigma? These are great questions that we've just recently heard that we want to start studying and understanding. How do we better treat that? Certainly, again, money, right? So, the silent option, please bid, I'll be bidding over there as well. These are, small amounts of money add up very quickly across 17 patient advocacy groups. And again, allow our research to really focus, purchase the tools, the resources they need to advance this field. And most importantly, all of this allows the researchers, the physicians, the scientists to be in the lab and to do this work and get this done and advance this. So this slide represents the Dystonia Coalition enrollment. Focal dystonia, right, again, meaning that it affects one body region. We have over 2,500 people enrolled. And specifically, we have almost 1,000 with just upper face involvement, and that's that category of blepharospasm. So this is a very rich resource to start studying and thinking about dystonia and specifically blepharospasm. And again, this is over 10 years now when we started this study, and you can see that the numbers continue to increase. On the left here, this is the total enrollment, as I mentioned, nearly 3,600. On the right, we're now able to look at natural history. How does this look longitudinally? How does this look over time? Is the disease progressing? Is it changing? How is it responding to therapy? And so we have 1,400 plus patients who we've been able to get follow-up data on and see how these things are changing. And that's as I'm going to mention, a critical role to understand this research clinical trial readiness. In the first talk, we heard about the definition of dystonia. This effort, Dystonia Coalition, these patient advocacy groups, helping this out, allowed us to publish this paper here, Phenomenology and Classification of Dystonia, a consensus update. So it took us a bunch of the expert neurologists and other clinicians to really come together and describe this. And this was an update in 2011 as to how we think about dystonia, blepharospasm included. and thinking about it on two axes, right? Clinical characteristics, again, I've harped on that, I'm going to continue to talk about the importance of that, right? How do we define it? How do we include people into studies, clinically and research? And that's very important. And then at some level, we need to think about the cause, right? And that's going to be part of my second talk today, exploring the cause and what that looks like. Thinking about these independently has utility because there are separate efforts, and not until we can characterize patients can we better understand the cause, better understand treatments. These are the results, right? And so we heard this in the first portion of the talk today. These are the clinical characteristics, and hopefully this is big enough and projecting. If not, I'm going to kind of just go through the highlights here. On the left, these are the characteristics on average. Everyone's an individual, we respect that, we understand that, but on average, the patients enrolled in this study were 64 years old. The age of onset of blepharospasm was 51 years old, so that's that concept that this tends to affect people in that age range. If I, as a clinician, see a 25-year-old come into my clinic and they form blepharospasm, I'm scratching my head, right? That doesn't fit at least the average. Certainly it could be, but maybe we need to explore that a little more. Maybe we need to talk about what that means with that patient and think about that. And certainly when we think about enrolling that participant in research trials, we want to think hard about that and be able to justify that if it's not the normal person with blepharospasm. Patients have blepharospasm generally for life after it develops, right? So we measured them 12 years after their onset. Again, women, females seem to be at a higher risk of at least us recognizing this and enrolling these trials. And so we need to understand that, right? Are there factors of being a woman or being female that put you at a higher risk of dystonia? And there's some research along those lines. So these are important things that help guide us. And then areas affected, right? So not just the eyes are affected. There are other regions of the body that are affected. I'm going to go into that a little bit more, so I'm not going to highlight that here. This plot on the right, which probably is also very difficult to see, demonstrates on 1, 2, 3, 4, 5 blue boxes. Each of those blue boxes represents a different type of dystonia. On the left is a genetic form of dystonia. The axis on the left is the age, right? So as you go up that left axis, the age is increasing. So the leftmost blue box is genetic form of dystonia. The next right box is writer's cramp, so dystonia that affects the hand. The next one being that dystonia that affects the neck. Laryngeal dystonia being the next box, and then blepharospasm, the red box on the right. And the idea being that there are differences as far as when the patients developed these disorders. And so these are clues, right? Why does blepharospasm affect people in their later life? And so we want to understand that. Is that hormonal? Is that degenerative? What's going on in the body and the brain to contribute that? And how can we utilize this as clue? So characterizing and understanding these clinical components are very critical in helping us to ask these questions. In addition, we needed to better define dystonia that affect one body region versus multiple body regions. And again, this is important because if I really want to understand focal dystonia, are there particular areas in the brain that control the eyes that are affected? Maybe I don't want to look at somebody who has the neck involved, right? The foot involved, because maybe I'm getting abnormal signals in my research study, my neuroimaging study that I'm going to tell you about later. And so we really want to be able to, again, very crisply, very clearly classify these dystonia subtypes, recognizing in a consensus way that focal blepharospasm, focal meaning one body region, right? Is one body region just the upper face, or is it the face as a whole, right? This is a debate in the field where the world experts have disagreement, and we don't know how to categorize that. So sorting this out and making sure that study 1 that calls focal dystonia is aligned with study 2 that calls focal dystonia. We want to make sure that study 1 doesn't just include eye blinking, when study 2 includes eye blinking, oral mandibular, tongue involvement, neck involvement, and calls that focal because it's the head, right? And so these are pretty simple but critical measures for us to really advance the field. And so this is a publication that recently came out that helps us to identify this and to categorize patients into research and understand that. And so by doing this, we learn. This is a study that our group at Washington University did. This was when dystonia affects the neck to start, and only the neck. The majority don't spread. 61% do not spread to other body regions, from the neck to the mouth, from the neck to the voice, from the neck to the eyes. There's a small percentage that does, and that's reflected on the left figure here. This is a figure that represents a face, cartoon of a face, the nose pointing to the right of the slide, ear in the middle. And I've circled in red the region of the upper face blepharospasm on the left here. When dystonia starts in that region, it spreads to the neck 64% of the time. So that's a high percentage, right? Blepharospasm, I'm going to show you in another slide, has a much higher propensity to spread to other body regions than other dystonias. Why? How can we slow that down? What can we do to understand that? And again, understanding that and knowing that, if the disease is getting worse, right, if we do a study in the first 6 months of blepharospasm and the dystonia gets worse, is that because that treatment failed? Maybe not, right? That was the natural history. That's what we anticipated. So we have to be able to predict that, to be able to determine that. And similarly, sorry, down the right here is when it starts in the neck. 18% spread to other body regions. This seems to be more evenly distributed, right? So when it starts in another body region outside of the eyes, it tends to spread to the face equally to how it spreads to the lower face, the jaw, the tongue, the voice, and so on and so forth. So there are differences in dystonia on what body region is affected with respect to age and with respect to how it spreads. And these are important considerations. This slide here, I'm just going to tell you, this is the probability on the left, this axis, of spread to other body regions. This is for different forms of dystonia. Cervical, dystonia that affects the neck. Hand dystonia, dystonia that affects the hand. Laryngeal dystonia, those are the green, red, and orange lines. There's very low risk of spread over time, at least in the 10-year study on the timeline here. So each of, moving across this axis, we're increasing in time. So from 0 to 10 years, from the time of onset of dystonia, does that dystonia spread? Blue is blepharospasm. So yeah, it sure does. It spreads a lot more frequently and a lot earlier than the other forms of neck, hand, and laryngeal dystonia. In fact, 50%, half of patients who develop eye symptoms, their dystonia spreads to another body region. Again, why? How fast? And so this summarizes that plot, because I know that was difficult to see. Blepharospasm spread to other body regions is more frequent than other focal onset sites. The mean of spread is about 1.9 years, right? So, again, talking to that patient in the clinic who just had onset of spasms in their eyes, and they've seen me 3 months after that onset, there's a 50% flip of a coin that this might start to affect other body regions, and we need to keep an eye on that. We need to understand that. We need to think about that. And when blepharospasm does spread, it most frequently, spreads to the jaw, the tongue, and the neck, right? 84.5% spread to this oral mandibular, the jaw, the lower face, 45% spread to the neck, and then all the other regions of the body are much less lower. So it does tend to stick in this head-neck region, even when it does spread. And I think I had this conversation at breakfast this morning, family history. About 25% or 1/4 of patients with blepharospasm, if you really dig down deep, have a family member who's affected by dystonia of some type. And this implies a genetic component. I'll talk about that a little bit in my second segment of my talk. But that family history, when there is a family history present, if you know mom, dad, brother, sister, son, daughter have a form of dystonia, there's going to be an increased risk of spread from that eye region to other body regions. Again, we don't fully understand why, but these are questions we're starting to ask ourselves. What's the propensity, what's contributing to that? Another component is validating tools, right? So the Dystonia Coalition research, the patient advocacy groups allow us to validate tools to major severity, right? So I can look at you and I can say you've got a mild, moderate, severe dystonia. I can rate it from 0 to 10. How do we link that up across clinicians? How do we link that up across researchers, across the board? And there are various scales to do that. These are meant to be objective scales, but certainly there's a subjective component. I am looking at someone, I'm checking a box, 0 to 10 or 0 to 4 in each of these. I'm not going to get into the details of these scales, but there are 3 primary scales in the field: the Blepharospasm Severity Rating Scale, BSRS, the Jacob Rating Scale, named after Joe Jacob in Texas, and the Global Dystonia Severity Rating Scale. And each of these scales have specific strengths and weaknesses. Understanding that being able to look at 950 patients in a dystonia coalition, being able to have independent researchers rate these and make sure that there's agreement upon those is extremely valuable, again, for prepping for a clinical trial. We want to be able to make sure that there are no biases, that we use these tools to measure dystonia progression, the spread, the severity, and when we have better treatments available, the response to those treatments. And that's absolutely critical to prove that those treatments are working. People aren't perfect. The Dystonia Medical Research Foundation and the EBRF are supporting efforts to create artificial intelligence. This is pretty cool, right? A video, I'm on video right now, and in a few years somebody may be able to record this, put this into a machine and determine with confidence whether I do or do not have blepharospasm and how severe that is. That eliminates myself, that bias on this end. These are cool advancements that will allow us to do better research, to better identify blepharospasm, right? How long does it take you to get in to see a surgeon, a neurologist, right? If you can sit in front of an app, a computer, and potentially get that diagnosis in the future, these are potentially good things. So the key points of this portion of the talk, patient advocacy groups are absolutely critical in supporting large-scale initiatives such as the Dystonia Coalition and defining dystonia, describing dystonia, and understanding how dystonia progresses, including blepharospasm, over time. We have had recent success in knocking off some of those research priorities just recently defined by the Dystonia Coalition and the group at the NIH, specifically clinical characterization and understanding natural history, describing dystonia, understanding how it progresses over time. This characterization improves clinical care. I can have better, more informed conversations with my patients and so can other clinicians. But more importantly, it also allows us to make that next step. I know we're all frustrated. I know we don't want that treatment. We want a cure now. But this allows us, this is progressing. We're making progress, and this is a big part of that. And of course, specifically, we're studying and we're understanding patients with blepharospasm. The spread that occurs is later onset. The disease itself is later onset than other focal dystonias. It's more likely to spread, and there's a higher risk of spread with positive family history, FH family history. So that is the end of my discussion as well. I think we're staying on time. I will also take questions if that's okay, Dr. Old, so we can do that later. This is our institution and our group at Movement Disorders at Washington University, so a special thanks to all of them and everyone who's here to support us. Thank you. Question here?
My doctor gave me DIBY to help the Zoom work longer. And it's for Parkinson's, but it's for supposedly they don't have Parkinson's. So does that really work, or is that? It seems to.
Yeah. So I'm sorry, I didn't hear what the product was.
DIBY. I'm probably saying it wrong.
Right. So DIBY is the question. I'm not familiar with that product. I think that we can kind of talk offline and try to sort through that and identify that. But I think that you're touching on a point of education, right? Perhaps you're educating on potentially available resources and tools that we can use. But certainly, not striking a bell in my expert's mind. Maybe this is a product we need to explore more, research more, or maybe it has been, and so that's a component of research that really helps.
I know one doctor gave it to me. Okay. One doctor gave it to me, and then another doctor said that works. So we try.
Sure. And from my perspective, this is the importance of research, right? So there are many things that may work. If you Google blepharospasm treatment, there are going to be capitalists online, right? They're going to sell you a product, a placebo pill, something, right, to make that. And we have to be very careful. There are other things that anecdotally people believe work, right? Not a specific example, but it worked. It worked for me. I'm going to put it on Facebook. I'm going to blast out to the world. Perhaps there are risks that are associated with that we don't know and in that. And so this is an important component to make sure that you're talking with your doctor, make sure that that's appropriately approved by your doctor, and it sounds like it was in this case. And then, maybe this isn't a well-known treatment, so let's research this, right? Let's look at people, many people with blepharospasm, let's treat them in a blind fashion. Some get the drug, some don't get it. We use AI, for instance, or experts in the field who are blinded, who aren't treating you, who aren't biased, who don't want to, aren't desperate for a treatment. And we all are, of course, but in that situation, they have less to consider with respect to that success. And so I think that that's absolutely the point and why this research is so important to understand and think about these new products that folks are thinking about.
Yeah, I think that's carbidopa levodopa. I had to Google it because it's a brand name. I think that's carbidopa.
Got it. Yeah, okay, yes, of course.
It's a generic form.
So then you go break into
Perfect. So carbidopa levodopa is certainly appropriate as a trial in these disorders, or again, talk with your doctor. I laugh because I don't know the trade name of carbidopa levodopa. I use it every day of my life and in treatment, but you know, we try to take generic, we try to say unbiased in medicine and use these generic names. There are a subset of patients with dystonia, focal dystonia or other dystonias, that do respond exquisitely well to dopamine replacement, carbidopa levodopa. Again, talk to your doctor. There are potential risks, side effects that can occur with that. It is a very small percentage of folks that do respond. When they respond, it's an exquisite response. It's very obvious. If it doesn't respond, then certainly talk with your doctor about it.
I was just following up. Is that levodopa, is that on top of Botox or in conjunction with it?
Yeah, so I would speak with your physician about that option and discuss that strategy. You know, specifically if I'm treating someone, I don't want to do two things at once. It gets complicated, right? Because if you get better or worse, is it the drug? Is it is it drug one? Is it drug two? And so timing that and thinking about that in a logistic way with your doctor would be important. It's not unreasonable for somebody to be on both of those therapies at the same time.
I was just wondering, I just in the last few years during the pandemic was diagnosed with blepharospasm, and then sort of self-diagnosed actually, and then I started noticing my head coming down, and that was irritating me as I was walking, since everyone was walking during the pandemic, and I wasn't sure whether that had actually been happening at the same time, or I was just so focused on my eyes at the time that I didn't notice. I'm starting to think now that maybe it was a slow onset after would that be more likely?
Yeah, again, you're your own individual. You can differ from the norm, but these data suggest that when experts are looking at these patients over time, that's exactly what happens. It starts in the eyes, months, a couple of years pass by, and then it starts to affect other body regions and cities. Yeah.
Sorry, can I ask a question? Is blepharospasm more appropriately treated by an ophthalmologist or a neurologist?
That's a really good question. I think that the answer is who has
the question was, is blepharospasm more accurately treated or effectively treated by an ophthalmologist or a neurologist?
Yeah, so I think that's a question to ask your ophthalmologist and neurologist as far as their comfort. The specific reason is there are a lot of wonderful ophthalmologists who have a lot of experience in treating this very well. There are others that don't, and same in neurology, right? So I'm a movement disorder neurologist. I'm an expert in movement disorders. This is what I do all the time. So I have a lot of expertise in thinking about this. And I might have other tools that an ophthalmologist doesn't have, but the ophthalmologist also has tools that I don't. So you know, having that conversation and thinking about that and with that treating doctor, whether they're a neurologist or ophthalmologist, how qualified are you? What are my options? And are there other potential options that I can
The reason I ask is that I've seen an ophthalmologist, but never seen a neurologist. And the doctors invited me to see a neurologist after I'd done sleep studies. So I just wanted to know, should I go down that path just to find out more? Because I've seen a neurosurgeon over another issue, and I thought maybe it was something to do with that, but the doctors now thought that a neurosurgeon isn't the same as a neurologist.
Yeah, so I think the ophthalmologists are going to certainly be focused on the eyes. If there are symptoms or signs that might affect you in other body regions, like the neck or the jaw, you know, hey, my neck is sore and kinks some way, that might be a consideration to talk to that ophthalmologist about, is this the time to see a neurologist? But I think if you're having success in treatment and you have established a relationship with that ophthalmologist with respect to the eye movements, it would be reasonable to stay with that physician to treat. Great question.
Can you just clarify in family history, does that include Parkinson's, essential tremor, all forms of dystonia? Because clearly people here are concerned if they're passing it on to their children and grandchildren.
Yeah, so that's a great question. It's very complex to answer, right? Because there's a lot of overlap with respect to these disorders, Parkinson's disease and dystonia. People with Parkinson's disease get dystonia as part of their disease and also as a result of their treatment. But because you have dystonia doesn't mean you have Parkinson's disease. And so answering that question is a little bit challenging because perhaps grandma was diagnosed with Parkinson's disease, but in fact it was dystonia or vice versa. We didn't know as much 30 years ago in the context of that slide that we do now. And so that's a potential bias error that we can have in thinking about that. And the best studies on this occur when we're able to lay eyes on patients and their family members to make those assessments and determine that.
Good morning, I'm Josette Beverly. I'm the supporting cast to Rodney Beverly. And my question has to do with, as a neurologist, I think one of the kind of frustrating things is when the blepharospasm spreads, and like we have a neurologist, we have a neuro-ophthalmologist, and we have an ENT, and everybody works in their own wheelhouse, and we also are seen by doctors by NIH, and we got all this stuff on the left-hand side with this arm, we're trying to figure out how, and then because when who's doing the Botox in the eyes, and they're concerned with the level of how much Botox you're receiving. I guess just trying to, we call our neurologist our quarterback. And we kind of look to him to kind of help us guide and navigate like who to see. How do we kind of, what's the best way for us to advocate for ourselves with respect to if there's a particular area that we want to explore, maybe doing some injections. And is there alternative ways to maybe to injection when you have areas that may not necessarily be good for injecting, like hypofrontis, apparently is having spasms, and you can't inject the swollen muscle. So I think that's where we're kind of, I don't know if I asked the question properly or not.
Yeah, so I think these are great questions, right? The question relates to this concept of each expert has kind of a region of the body or a component they consider. And the answer to that is also very complex because it really depends on the healthcare system you're within and the efforts that are done within that. I think this is a role where the patient advocacy groups can help, right? So I think finding a quarterback on that team, defining that mutually, as you've done as that neurologist, and talking about the options, right? So, in our center, we certainly do our best to coordinate those botulinum toxin injections. If I can't inject a voice, we certainly try to have a team there, but that's not possible everywhere in the world or in the country. And so thinking about that strategically and talking about your independent teams and the resources available there is the best strategy, which it sounds like you're doing a good job of.
Okay, thank you, Dr. Norris. Dr. Norris will be making another presentation this afternoon, and we have a Q&A session. But let's give him a big round of applause.